webinars to enlighten the use of and Oseltamivir to the doctors and practicing pediatricians and also teaching faculty so that the patients will be benefited. Yeah, able to see, sir?
Yes, sir.
Yeah. So today's topic is role of Oseltamivir in flu management. I welcome my panelists, Dr. Sungoj Bhaskar sir, President PATS, and also Dr. Sri Krishna sir, Head of the Department, Professor of Pediatrics and Apollo Institute of Medical Sciences and Research. And these are the contents to give a brief before the going into the case discussions and questionnaire. Few common questions what parents and doctors will be having doubts. So those will be dealt after the basic introduction will be given for the about the influenza incidence, challenges and complications, and also clinical evidences of oseltamivir and what are the guidelines recommendation for empiric user. These are the headings. We'll give the brief introduction for 5 to 10 minutes. So you know very well what we know about influenza in India. So influenza is a commonest whenever the monsoon is there and whenever the climate is not sun is not there that much. So then the incidence of influenza will be very common in the thing. Which season? So these are the seasons which rainy season and also winter. These are the two seasons where the incidence of influenza will be very high. We should be very much careful with other viral illnesses like dengue or influenza like illnesses or gastroenteritis. These are all the causes which viral causes will be there for the causing. And also we should be keep in mind two viruses which are much important. One is RSV virus and adenovirus. In RSV virus, what happens is there may be mixed infections also, but RSV virus will not have this much headache, body pains, myalgia, and malaise will not be there when compared to the influenza. And coming to the adenovirus, it will be mostly affected non-respiratory also and respiratory also. So we have to be, these are the differential diagnosis when we have to think of the viral origins. So the in Indian data, 5 to 10% of all acute respiratory infections are due to the influenza, and 10 out of 100 child year suffers from every year suffer from influenza, and 180 to 178 per thousand children per year below 1 to 2 years. There is a two different studies from North India where the incidence of influenza is very high, 15 to 20%, and influenza associated with acute respiratory illness 33 to 44% per thousand children. And we have two pandemics. One is 2009 and 2019, where more positivity is there and more death are there. This is the chart where it is taken from the Purple Book of the Immunization. So it has shown two peaks, one in January to April and second is July to October. In these two peaks, what happens is the incidence of influenza will increase and most cases will be reported in this time. And in winter, like after rainy season, there will be some peak for the post monsoon also. So this is the chart where shows two peaks in January to April and July to October. And coming to the global burden of disease 2017, this is the source where we have taken. Total 5,88,000 hospitalization cases are there and 26,000 deaths are there. So this is, so you can see the burden of deaths, how many deaths are there because of the influenza causing respiratory tract, lower respiratory tract infections. And year wise they have divided the same the cases, number of cases and number of deaths. So I'll not say all the years, but in 2022 there are 12,881 registered cases, out of which 399 cases are deaths are there. So the influenza H1N1 we have to keep in seasonal flu, influenza A, H1N1. So year wise cases are there. And the pattern of circulating strain, see we have four strains, you know very well. One is H1N1, H3N2, and also Victoria and other strain is there. These are Yamagata. So these strains will be different in different zones. In but and the circulating strains will be peak in one zone in January and March in North India, whereas in Central India, July to September, Southern India, September to November, and in winter and monsoon peak, as earlier said in the chart, in winter and monsoon, there will be a peak occurs in the influenza number of cases. And there is a study in 7 years cumulative study, which was done in Chennai, Tamil Nadu, King Institute of Preventive Medicine and Research, where 36,670 specimens were conducted and duration of study is 7 years. Here, most of the cases positivity is seen in onset of monsoon and peaks during the post-monsoon months. So the studies reveals and the incidence reveals and our practice itself reveals these cases are more common in winter and post-monsoon. And when you talk about influenza, we have to talk about the differential diagnosis, what should be kept in mind. One is influenza-like illness, and second is H1N1, what we are dealing with now, and severe acute respiratory illness, and COVID-19. But when you think of the differential, how to exclude and come to conclusion of H1N1. In COVID, in 2020, 21, 22, we have more cases of COVID-19. Now, they are very less and severity has also come down. But it causes multi-system involvement, causing loss of smell, loss of taste, and also diarrhea, vomitings. These are all very much common with the COVID-19. Whereas influenza-like illness, the severity will not be there. The breathlessness, the tachycardia will be more with H1N1. Myalgia, headache, malaise, these are all weakness will be with H1N1 will be more. And you know very well, severe acute respiratory illness, they are having similar presentation like H1N1, but we have to be able to differentiate severe acute respiratory illness from H1 because the headache, systemic illness will not be there. So other associated symptoms will not be there with H1N1. So there is a bar diagram where year-wise number of cases registered and number of deaths are there. As earlier said, in 2019, there are registered cases are to the cases of influenza infection is 28,798 and deaths are 1,218. So this is only bar diagram statistics, which is important for the logistics and other purpose. And for a brief note on types of influenza, we have influenza A, influenza B, and influenza C. And influenza A is the most frequent epidemics will be caused in periodic pandemics because there will be a minor antigenic variation. Always the influenza virus is a RNA virus. This changes genetic sequence very rapidly. So that's why the antigenic variation, mutagenic variation will be very high in the influenza A. So influenza B virus infects only humans but causes local epidemics. Influenza C can infect animals also, humans. But common is 60 to 70% of the cases will be influenza type A. And concurrently, as earlier said, we have two strains common, H1N1 and H3N2, which are commonly circulating in humans. And transmission of flu virus because of the droplet infection, if from 6 feet away also, it can spread to the other normal public, normal people. These droplets, what happens? The droplet infection can land in the mouth and noses of the people, and they inhale into the lungs. That will cause inflammation in the lung alveoli, causing this pneumonia-like symptoms, and also prominent bronchovascular dilatation, the constriction, and causing the X-ray findings and other things. So we should tell them people should stay away from the affected person, and also important to wash hands often with soap and water. And here the symptoms, the infected people will be sick 1 day before the symptoms develop and also up to 5 to 7 days after becoming sick. So the children may pass the virus for longer than 7 days to 10 days. And here, as earlier said, the differential diagnosis, symptomatic differentiation of influenza-like illness, H1N1, and severe acute respiratory infection and COVID-19. Here you can see, I will tell only 2 points in this: severe acute respiratory infections and this H1N1. The headache, myalgia, these are body pains will be very high in H1N1. It will be may or may not will be in the SARI. So these are the things how to differentiate the clinical scenarios. And you know very well the benefits of empiric use of and early use of Oseltamivir is proven in the clinical trials where there was a prospective study was done, and data on the lower respiratory tract complications and antibiotic use and also hospitalization. They have studied how many cases are affected with after starting oseltamivir, what is the improvement in the patient, and these are all the prospective study done. And it's a wonder to say that antibiotic usage has come down by 26.7%, and the complications of lower respiratory tract infections has come down, resulting in the antibiotic by 55%. And it's a good news for the parents and also small nursing homes and small clinics where we can treat on OPD basis these cases of influenza, where hospitalization has come down by 59%. How much benefit for the family members, parents, and also the hospitals will be having a good name. As a clinician, pediatrician will be having a blessings and wishes from the parents who got their children very much treated with oseltamivir. So this is the introduction. Now it's a time to utilize my services from the our panelist, Dr. Sri Krishna Garu. Please go ahead for the case one discussion, sir. Please. Sri Krishna, sir.
Thank you, Dr. Sridhar. From last 3 months, there is a peak of influenza cases in many hospitals, right from simple upper respiratory infection, mimicking a disease, or a severe case of pneumonia that required even a ventilator support. Here we have an example of a 4-year-old boy admitted with history of fever for last 6 days, along with the cough and cold for 5 days. On examination, the child is having respiratory rate of 45 per minute, along with the irritability. As is a 4-year-old, definitely this is a respiratory distress. Chest auscultation showed bilateral crepitations. All other parameters were normal, which is a typical of any viral infection. The weight of the child is 15 kg, that is normal. Then we get out, how do we proceed? What are the initial managements? And what are the basic investigations? How do we start do we start antibiotic on the day of admission? If so, which antibiotic? As we have seen, this is a typical case what we see in our ICU practice. So these doubts do come. So how do we proceed? Here, as the child is sick, having respiratory distress, we should start the oxygen in a convenient method for the child, and give supporting care like IV fluids and nutrition, and do the basic investigations. The basic investigation includes CBP, which is usually for viral infection. It is a normal picture or slightly decreased neutrophil count. And chest X-ray is a basic test for these cases of respiratory distress. Do we start the antibiotic on the day of admission? So the IMNCA guidelines, they say that if there is a typical upper respiratory infection, that is only cough, cold without respiratory distress, 90% to 95% of the times it is a viral infection, and you can wait for the antibiotic to start. So this is a good guidelines where you can wait for the antibiotic if there is a pure upper respiratory infection. But when the child is having respiratory distress, it is better to start antibiotic. That's what the IMNCA guideline says. And the most preferred antibiotic in this case is amoxicillin. Even though this picture looks like a viral, but it is preferred to start with amoxicillin. Next. So we did the same. The CBP showed the normal picture. The chest X-ray is showing bilateral interstitial infiltrates present, and the viral panel is done in our hospital, which showed H3N2 positive for influenza A. At present, influenza, the H3N2 is most prevalent, we have seen. So because it is shown the positive for influenza, we have started on antiviral drugs that can shorten the illness. Here, does the case require antiviral drugs? Way back, 20 years back, there are no antiviral drugs available, and most of the times we used to wait just for the symptoms to improve on their own. Of course, there is a significant number of deaths used to be there, we have seen, but now we have seen, because among all antiviral drugs, the oseltamivir is available especially for the influenza. So because oseltamivir can shorten the symptoms and signs if we start within 48 hours of the illness. So we have started the oseltamivir with a 3 mg per kg body weight in oral form, and twice daily for 5 days, which is effective in this case. So the emergency warning signs of flu sickness. Here, this is a good guidelines were given by WHO, where you can suspect flu. Usually in day-to-day terminologies, many people will feel that even simple cough cold also flu. Of course, they are also mimic same thing, but particularly in our sense, flu means the influenza infection causing chest symptoms and causing the discomfort to the patient. So if you take in that sense, in children, the fast breathing or trouble breathing, the bluish skin color, and not drinking enough fluids, not waking up or not interacting, or being so irritable that the child doesn't want to be held, and other like there's flu symptoms improve but then return with fever or worse cough, and fever with rash. Here the particular one point is flu viral infection is known to have secondary bacterial infections also. This was almost 100 years back. There was a big epidemic went on during soon after First World War, where nearly 5 lakh deaths happened in India itself, and most of the time it was a flu followed by a secondary bacterial infections. That made the most of the women and children have died during that period. So that means the treating flu illness, even though it's a viral and sometimes self-limiting, treating the flu illness with early antiviral drug is always useful. Next. So as you know, the complications include the pneumonia, bronchitis, the routine ear infections, worsening of existing diseases like asthma and COPD, ARDS, and even death also can happen just with acute respiratory infections, especially viral infections. So the other treatment, what is the treatment suggested? Usually the supporting treatment is very, very important, like rest to the patient and increase fluid consumption. And the role of cough suppressants here, I want to discuss particularly about this because of the recent issue also, that there is no particular role of any cough suppressant. Please avoid all antihistaminic drugs whenever there are chest symptoms. Similarly, the bronchodilators have limited role unless there is a bronchospasm signs like bilateral wheezing, or regarding the mucolytic, they may have some effect provided the child hydration is good. That means the child hydration is much more important than just giving a mucolytic drugs, and he should be supported with the antipyretics and such as paracetamol, and please avoid other antipyretics like powerful mefenamic acid or ibugesic for such children. And usually most of the patients with influenza recover well within 3 days if we start antiviral drugs like oseltamivir, whereas those who have not started antiviral drugs usually taking 2 to 3 days more time. So here already one point about the antiviral drugs here, how they are working. They are, if you recollect, long back, almost 20, 25 years back, there was a drug available, amantadine. I don't know whether it is available now or not, but they used to suggest that in flu, this amantadine also works. What is the difference between this presently available oseltamivir and amantadine, previously amantadine? There are two types of enzymes present in the influenza virus, one neuroaminidase and second adamantinins. And here the neuroamidase enzyme inhibitors are the oseltamivir and zanamivir. And in this oseltamivir, both are available in the world at present, but oseltamivir specially available even in India. And this is a picture shows how the oseltamivir activity, neuroamidase activity is there. Here the host cell where it is present in the layer of the oseltamivir, neuroamidase enzyme activity at the peripheral layer of the virus, and this results in usually because of this neuroamidase activity, new virions will come, and the release of new virions continued causing the viral replication. Here, this particular step is blocked by the oseltamivir. That results in there is no proliferation of the new virions. So that halts the viral replication so that the early progression can be seen. So it means that, to summarize, that oseltamivir is a potent and selective inhibitor of neuroamidase enzyme of the both influenza virus A and B, and it is converted to it is a prodrug. Basically what we are giving is a prodrug, oseltamivir, which it gets converted into the in the liver as a oseltamivir carboxylate. This is the one which is the active form, and as I already told that it inhibits the influenza viral replication, and also it prevents further spread of infection from one person to other. This is a very important aspect, especially if one child is affected or one adult is affected in the family. The influenza can spread rapidly to other members, and by using oseltamivir you can minimize the spread of this infection also. And it's also useful for all strains of influenza A and B. So this is available, and it is at present oseltamivir is approved in more than 100 countries, and AAP strongly recommends this. Even Indian Academy of Pediatrics also has approved to use oseltamivir in India.
Yes, sir. It's a very good case presentation by Sri Krishna, sir. I want to put a word for 10 seconds. 3 days back, 5 days back, we got admitted, one child admitted in the hospital, and we advised on phone because the patient was sent by me and advised on phone to start the Fluvir, but the parents unable to get the in a peripheral hospital. They unable to get the Fluvir. They waited for after 48 hours. I went there. Child was not improved that much, but I started hydrocortisone. So better, but not complete improvement is there. So I have seen the treatment part. If Fluvir is not given by the sisters, I asked them why you have not given. Sir, they have not got the syrup. So immediately I said where to get. They brought that. Today I had discharged today morning the same child. Within 48 hours, child was dramatically improved, and total cough, cold, and distress has come down. So this is the latest experience of these 2 days, sir. So it's a nice drug which gives a very fast improvement. So I request now Sunkoj Bhaskar sir
It's
to
true,
start
Sridhar.
this.
What I have seen, the diagnosed cases, if you start oseltamivir, there is a
Uh,
clear-cut case of influenza, responds very well and very fast response we have noticed, even in our setup also.
Yes, sir. In peripheral, what happens is viral panel means it will be costing about say 3,600.
Yeah.
So they may not be able to spend on clinical scenario. We have to take a chance to start the Fluvir, sir. So that is the thing happened recently. So I request Sunkoj Bhaskar sir to start the second case discussion, sir. Please. Bhaskar sir.
Thank you, Dr. Sridhar, and good afternoon to my co-panelist, Dr. Sri Krishna, and the moderator, Dr. Sridhar, and the hetero family. I really appreciate for bringing out this panel discussion at right time for the benefit of our healthcare profession. So this girl whom we had seen maybe 3 weeks ago, he came with fever and running nose since last 6 days, with cough since last 3 days. Then we took the history in detail, and the significant point was She is a known asthmatic on irregular treatment. So when we examined the child, uh, fever was low grade, bouts of cough was there. It was almost paroxysmal. Then when we auscultated, there were bilateral crepitations along wide V's. So now the dilemma, once we heard the complaints, we took the history, we examined. Now how to move forward? Should we suspect flu infection in this child? Because now, as Dr. Sekshan has already told you, the season is going on for influenza virus infections, of course, along with RSV and other viruses. Then, if so, what is the criteria? And there is a past history of asthma. So, is it a simple post-viral asthma? So, if so, require should we prescribe only bronchodilators but not antivirals? Next slide, please. Next, please. Yeah. So, we had suspected we had to suspect this flu infection in this girl again due to the reason that there is a epidemic of magnitude. That's why we had suspected viral respiratory infection. Most probably it's a influenza infection. And past history, this child has a pre-existing illness, and we all know the viral infections, they themselves cause inflammatory airway disorders. And here in this child gets worsened because this child had already airway inflammatory disease, which will be worsened by the virus infection, particularly influenza virus. So we admitted the child became febrile, but wheeze was increasing. Wheeze was increasing. So we had to switch over from oxygen to HFNC. Then somehow it took 5 to 6 days to come over the wheeze, but child was not becoming stable. We did this bronchoscopy. We did BAL. It was showing bronchopulmonary aspergillosis. So what I'm trying to say is, the flu virus looks a simple virus, but it can cause these kind of complications, which may and which will lead to death, particularly in immunocompromised children or in children who have these pre-existing illnesses. So, however, at the time of discharge, we had advised her to have regular annual flu vaccine and along with preventive measures and as well asthma management. So what are the guideline recommendations here? WHO has clearly recommended, it has kept this drug in complementary category, and they had clearly put forward that it can be used empirically when you strongly suspect that it could be due to flu virus infection, and also in high risk groups. And the treatment has to be started again, as my earlier panelist, Dr. Sri Krishna told, we need to start Oseltamivir empirically as soon as possible once you strongly suspect in a child. Yeah. Simultaneously, we did investigations for this girl, and also we sent nasopharyngeal swab for RT-PCR, but we didn't wait until we get the report. It takes few hours, and also there are some pitfalls with this uh, PCR, RT-PCR reports. False negative, false positive are still there with this. So we didn't wait for the report, and particularly if a high-risk individual is exposed to a patient with influenza, again, we need to give chemoprophylaxis to those high-risk individuals, preferably with oseltamivir. Yeah, next, please. So, should we give empiric antimicrobials to treat all likely pathogens causing SARI? Yeah, again, we we try to promote antibiotic stewardship. So better we leave it to the discretion of you, the clinicians. But if you suspect there is a super infection or secondary infection, try to go with an antibiotic. preferably from the narrow spectrum antibiotics like amoxicillin. And empirical antibiotic treatment is based on the clinical diagnosis. Is it a nosocomial infection, that is hospital care associated pneumonia, or it is a community acquired pneumonia? If it is a healthcare associated pneumonia, we are more scary, and we try to give higher antibiotics if if required, antifungal as well. So this empirical therapy, as I told you earlier, includes neuraminidase inhibitor for the influenza. When there is a local circulation or local epidemic is going on in high risk groups, we should give empirical therapy with the neuraminidase inhibitor. Fortunately, it is available and as well affordable. So in adults with community acquired pneumonia who test positive for influenza, should the treatment regimen include antiviral therapy? Yes, we strongly recommend anti-influenza treatment with antiviral drug like Oseltamivir with community acquired pneumonia who test positive for influenza. So for inpatients, for those who are immunocompromised or those who have the coexisting disorders like diabetes or any other disease, particularly even undernourished, malnourished, all of them come under high risk group where we must start Oseltamivir. So, and to support our thinking, there are several observational studies show that the treatment with Oseltamivir is associated with reduced risk of death in patients who are hospitalized for community acute pneumonia and who tested positive for influenza virus. So treated within 2 days of symptom onset, or if we miss that, doesn't matter. At the earliest, after seeing the patient, we should start neuraminidase inhibitor like Oseltamivir at the earliest, which has a lot of benefits. It decreases the respiratory complications. It decreases the hospital stay. It saves some money to the patient and to the nation. So we need to use this drug empirically in inpatients and as well in high risk group people, as well as a chemoprophylactic drug for high risk individuals who are exposed or who may get exposed. Yeah, thank you. So in that girl, we took the chest X-ray. Chest X-ray, the one thing is very conspicuous here is hyperinflation of the lungs. As well, some interstitial infiltrates are there. Then we did CBP. CBP was normal as expected. And viral panel, RT-PCR, it was showing AH3N2. Now, which is very much prevalent in Telangana. Next, please. So this child, as I already described, child was given Oseltamivir along with asthma management and supportive therapy, and fever control early. Then subsequently, wheeze, respiratory distress, all had come down, settled but slowly, and we had to start antifungal treatment in this girl because this girl had developed bronchopulmonary aspergillosis. It's a confirmed case of bronchopulmonary aspergillosis. So my point here is, let us not take influenza virus easily in inpatients and as well in high risk groups. Otherwise, they will develop these kind of complications, prolonged hospital stay, and sometimes death. Thank you.
Yes, sir. Thank you, sir. It's a beautiful case, sir. The coexisting morbidity where the patient is suffering with asthma. We should keep in mind the balancely the treatment should be given for the asthma and also for the influenza. We shouldn't neglect the part and influenza, or we shouldn't get confused between the two. So, child may be complaining previously, child is having asthma, but you don't confuse between the asthma and influenza, so that you can treat both the balancely, and patient has to be kept in mind when discharge is done. It has to be given a prophylactic treatment for the asthma with the inhalers and other things. So the case 3 now, I request Sorumpur Sri Krishna Garu to start the case.
Thank you, Sridhar. Here, we have a 2-year-old boy admitted with high-grade fever for 2 days, along with the cough and cold for last 2 days, and breathlessness. Here, the child is restless with a respiratory rate of 60 per minute, and the fever of 103 Fahrenheit is noticed. So, how do we proceed? Do you want to start presumptive anti-flu therapy with Oseltamivir? Here, one thing I want to just give a clarification. Usually, we get doubt whenever cough, cold, fever comes. For the very first question comes, is it upper respiratory or lower respiratory? The golden rule is if there is any breathlessness, it has to be the lower respiratory and it needs admission and more supporting care. There is no question of thinking about such cases. Second point is it viral or bacterial? Here, many times the report says that 90 to 95% of the upper respiratory infections are viral, whereas the 70 to 75% of lower respiratory also viral. So when the viral infections are so predominant, in spite of knowing this also, we are habituated to start antibiotics. Presumptive antibiotic therapy we used to give, and based on the distress also many times our doctors start lower antibiotics till highest antibiotics also. Here, because when the report says that 70 to 75% of infections are viral, it is instead of thinking about presumptive antibiotic therapy, it's always better to think about presumptive antiviral therapy. Among the viral infections, the one for which an effective antiviral drug available is influenza. So obviously, we can always think about in such cases the presumptive therapy with the oseltamivir. What is the criteria? What is the supporting evidence? Here, in this particular case, as the child is having respiratory distress, we have to give life supporting measures along with oxygen and IV fluids, and if needed, ventilator support also. And presumptive antibiotics therapy, we already told that according to the IMNCA guidelines. Now the point comes with the presumptive anti-flu therapy. Next step. Here is the criteria. Here the guidelines says that antiviral treatment of influenza is recommended for all children with number one, suspected influenza-like illness. That means, how do you suspect? The fever with either severe cough or sore throat. Here, one more point is a fever with cough is very severe in viral infections compared to the bacterial infection. Most of the times, bacterial infections will have mild cough and it is wet cough. Whereas severe bouts of cough, dry cough is more typical of viral infections. So if the fever with dry cough, they always suspect the viral infection. And among that, influenza is most dangerous one. And those with the confirmed influenza who are hospitalized or having severe or progressive disease. So we need not wait till the flu report and viral panel report comes. You can straight away go for antiviral medication. And those children who are having underlying conditions that can compromise with the risk of complications of influenza, it need not sometimes, even though the viral panel is not available or it is costly, you cannot do. There is nothing wrong in giving oseltamivir in such cases also. So in all this, the antiviral treatment should be initiated as soon as possible, regardless of the duration of the illness. So this shows that don't hesitate to start antiviral drugs in all cases of lower respiratory tract infections. Now, this particular case, we have done CBP, which showed lymphocytosis with neutropenia. Again, the typical of any viral infection. And X-ray shows the bilateral interstitial infiltrates. And again, this viral panel became positive H3N2 for influenza A. Now, what is the dosage? We have discussed the need of oseltamivir and when to go, even as a prophylactic therapy before the report pending. Then the doubt comes about the what is the dosage and what is the recommendation. Here, this particular table has very clearly showed what is the treatment wise. If you see the first table here, For adults, it is 75 mg capsule twice daily, which is available. Whereas for the children, it is 3 mg per kg body weight. So roughly you can take that if the child is less than 15 kgs, he requires 60 mg per kg per day. Whereas 15 to 23, it is 90 mg per kg per day. 90 mg per day. Whereas 23 to 40 kgs, he requires 120 mg per day. And here remember the treatment part, it is given twice daily when you are treating the patient of influenza. Whereas the dose remains same when it's a matter of chemoprophylaxis. That means when somebody in the family is suffering with the influenza, and the other person is having the risk of getting the infection, he requires chemoprophylaxis, as in the previous speaker, Dr. Sunkol Bhaskar sir told, that this chemoprophylaxis also, the total dose is same, but it is divided in 10 days as a single dose per day. That means the dose remains same, but you are giving it for 10 days compared to the 5 days when you are treating the disease. This is the difference. That means we should remember the total dose is same, but if the same dose is given in 5 days when the case is detected, or as a prophylaxis, we are giving it for 10 days. Then what is the volume of oral suspension available in India? It is available as a 12 mg per each ml. So it is you can give as a 2.5 ml or 3.75 ml or 5 ml as per the weight indicates. So it is convenient for the pediatric as a pediatric suspension also. Next. And this case continued. The same child is having a 5-year-old sibling with a nephrotic syndrome on steroid therapy. And obviously, that sibling, when he is on steroid therapy, and this particular child is suffering with influenza, we get doubt. Is there any risk for the child? Because that child is on steroid immunosuppressant therapy. Do we recommend any preventive therapy? As already in the previous table, we have shown that what is a role. Here, as such, we get even doubt whether this patient require influenza vaccine also. Now, let me be clear. When there is a patient is on immunosuppressive therapy, there is no role of any vaccine. Whereas definitely there is a role of prophylactic antiviral drug, that is Oseltamivir. So here again I am repeating the dose for the prophylactic Oseltamivir. The total dose is same, 3 mg per kg per day, but it is in single OD dose and it should be given for 10 days. Next. Here, so antiviral in OP setting. Sometimes here, as in the previous case, this child, sibling is having a nephrotic syndrome and immunosuppressive therapy, even though he is not having any symptoms. So that means he requires OP setting only. Here, OP treatment itself. So who else require really OP treatment? Usually, when we come across the cases with upper respiratory infection, even though it is looking like influenza, we don't recommend Oseltamivir unless it is a lower respiratory infection. So, but in special situation, even with the symptoms of upper respiratory infections or without that also, where there is a risk, we advise the Oseltamivir for all those symptomatic who are not at high risk for influenza complications with confirmed influenza disease. So best timing is start within 48 hours of illness. Second is, it should be considered even for those any household contacts who are suffering with any immunosuppression, or if any child is there at home younger than 6 months and this particular patient is admitted, that is like a 2-year-old, 3-year-old child suffering with flu, and if there is a child of less than 6 months in the home, he also require Oseltamivir. Sorry. And high risk condition that predisposes them to complications of influenza. What are those high risk conditions? One already mentioned, that immunosuppression, immunosuppressive therapy, or immunosuppressive conditions like child suffering with malignancy, or any chronic heart disease or lung disease. So all these children require prophylactic antiviral drugs. So antiviral chemoprophylaxis is recommended for all such cases, and as an adjunct to vaccination. Even though the child has received vaccination, still they require prophylactic antiviral therapy because the child is having immunosuppression. And those who are not expected to mount an effective immune response with the previous vaccine, that means wherever the condition where there is a, you suspect the vaccine failure also. These are the cases which require prophylactic antiviral therapy.
Thank you, sir. So there's a why this case was considered is because in the family members, one of the child sibling is having the nephrotic syndrome. So it has to be given or not. So chemoprophylaxis has to be given for the children who are there. If the child is severity of the infection is very high, we have to give. We shouldn't neglect the other siblings or family members. We have to give a chemoprophylaxis at the same dose for the 10 days. This is the message what we have to give. And the next case, Sungoz Bhaskar sir, please elaborate, sir, please. Bhaskar sir.
Yeah, thank you, Dr. Sridhar. Here is an interesting case. A 12 years old girl was admitted with fever and joint pains for 4 days, and along with mild cough for 2 days. So again, we became little confused. Gender-wise, she's a girl. Age-wise, pre-adolescent or adolescent, and joint pains. So the first thing comes to our mind is autoimmune disorders. But as well, we do suspect any viral infection can present in this form: fever, myalgia, arthralgia. So then, subsequent history revealed she has mild cough since last 2 days. Then we examined the girl. Somehow, girl was restless, irritable, with cough and low-grade fever. Mild arthritis was there, and on auscultation, we could hear bilateral crepitations. So, what should we do? Should we rule out viral respiratory infection here, or should we consider only autoimmune disorder, or should we consider both? We are little confused, and then we moved forward and we did CVP and also ESR, which is not mentioned here. So CVP was normal. Again, ESR was normal. So somehow we got some relief that ESR is normal. Then we did ANA profile. Again, it came out to be normal. Then we thought we are lucky. It's not. At least we can rule out autoimmune disorder to some extent in this girl. Then we took chest X-ray. It was showing not very significant, but there are bilateral interstitial infiltrates. Then we did RT-PCR of nasopharyngeal swab. It was showing type B influenza virus. So the confirmed case of respiratory viral infection with influenza B, and because we should suspect we should suspect connective tissue disorder with flu cases. The reason is the 30% of the interstitial lung diseases or chronic lung diseases, they they present in the form of autoimmune disorders. So we do know that viral infections can trigger this interstitial lung disease, or it can worsen the existing interstitial lung disease in people who have this autoimmune disorder. So frequent viral infections might play a role in development and progression of this interstitial lung disease. We all know what is interstitial lung disease. It's a interstitium surrounding the alveoli. So whenever there is an infection or inflammation, it gets disturbed, and during recovery, there may be excess matrix formation, may lead to fibrosis. Then this oxygen, gas exchange, it gets disturbed, and the prognosis is very bad for ILDs. They will have this breathlessness, early fatigability, and it keeps worsening, and the death rate is too high in most of the ILDs. That is why all the patients with connective tissue disorder, particularly chronic lung disease, they should receive vaccination annually against influenza viruses. And when there is a sign of viral lower respiratory tract infection, we should start oseltamivir early, at the earliest in routine doses. So that is the interesting part of this case. Fortunately, the child was not having autoimmune disorder or interstitial lung disease. Just for to enlighten the complications of these influenza viruses, we have presented this case to you all. So, any change of clinical picture or medication or management between influenza type A or B, generally there are no significant changes in clinical presentation. There are no significant changes in medication. Management is the same for type A and type B. Influenza A is severe in adults and as well children. Same with influenza B, it's more severe in children below 5 years. The constitutional symptoms are same. Clinical pictures are same. Complications like pneumonia, again, same. But these mutations are more commonly seen in influenza virus. That's why we call it as a smart virus. It changes its genetic structure. Just now, our moderator had clearly explained how they change their, how they have these mutations, these variants, by virtue of these alterations of the genetic build. So they change their structure, thereby they escape the antibodies induced by the vaccine or the earlier infection, and they can come in a new form of disease. And they can infect people, they can infect even other animal species. And that's why nowadays we are seeing more of uh, zoonotic disorders particularly with the influenza A. And regarding vaccine, trivalent or quadrivalent is an issue nowadays. Some controversy is there, but there is no harm in giving quadrivalent vaccine because it includes both influenza A and influenza B. So to be on safer side, there is no harm in giving influenza vaccine having these four strains. So prevent how to prevent this from spreading it to others or from getting it from the infected person? One is thanks to the COVID pandemic, which had taught us all these things, hand hygiene, we particularly healthcare professionals, the most contaminated thing with us is our hands and our mobile phone. So we should wash our hands as frequently as possible with soap and water before we see any inpatient in ICUs particularly. If water and soap is not available, or at least you use this alcohol-based hand rubs uh, whenever you touch anything or you touch a sick patient or in ICUs. So sanitizers can be used. And we know the etiquette of cough and sneeze. Whenever you get a cough or sneeze, take a tissue or carry a handkerchief and put it against your mouth so that droplets from your mouth doesn't spread to others. It can spread up to 6 feet. If it is an aerosol, it may spread beyond 6 feet. So have a handkerchief. Or people don't have handkerchief or tissue. Please cough into your elbow, cough or sneeze into your elbow so that it will stick to your elbow skin only. But we know these viral infections, they do spread through the surfaces, through fomites. So try to clean your mobile, tabletops, or whatever you handle, stethoscopes, doorknobs, bathroom taps, especially if any of our neighboring person is ill. Pharmacological, we know vaccination is very, very important for children from 6 months old to the geriatric population as well every year. And prophylactically, thank God, we got oral medicine. It can be used prophylactically. That is the neuraminidase inhibitor, oseltamivir.
Yes, sir. So, thank you, sir. It's a very interesting case because the child is having, it's not a normal presentation for all the influenza-like cases. Child is 12 years old and presented with joint pains. So, we have to keep in mind connective tissue disorders. But in this case, ANA profile is negative. So, but these viral infections can flare up the connective tissue disorders always, as it flares up asthma. In the similar way, it flares up the connective tissue disorders also. So we have to keep in mind when the joint pains are there. But this case was is ANA negative and so treated with oseltamivir early and child improved. And coming to the few questions which are common questions, these already in the presentation they have covered, but still few people who had joined late may be having the benefit of these questions. So the first question to Sunkoj Bhaskar sir: has the incidence of viral infections increased, sir? What could be the possible reasons?
In one of your slides presentation, there is a significant rise in viral infections across the world. The reasons are multiple and complex. So we human beings are partly responsible to this increased incidence of the viral infections because our population is exploding and lack of public health measures, clean water is not available, proper sanitation is not there, and in most of the developing countries, the iron deficiency anemia is more than 75% in children. So the undernourished, malnourished, all these things can create. And as well, in this modern world, the excessive or intensified air travel between countries carrying the viruses along with them. So that's how it's multiplying and increasing. And secondly, the environmental issues like global warming, which favors the increased growth of the viruses, and deforestation again by human beings. Forests are the places for the animals which carry viruses. Now, what we are doing, we are encroaching into the animal habitats. Thereby, the animals are coming into our residential areas like uh, Tirutapulli, what is it called? This this Sridhar, what is it called? Tirutapulli?
Sir?
This uh, the animals which are coming into the residential areas. This uh, yeah. So the animals carrying these viruses are coming into the human residences and spreading the zoonotic diseases. Thirdly, viruses have become more smart. Particularly now, just now we had seen influenza A virus. It mutates itself. It changes its genetic structure, escapes the attack by the antibodies, and creates new forms of diseases. So these are multiple reasons why the viral infections are increasing. And
Yes.
this influenza A, by virtue of its antigenic drift, this special characteristic feature of evolution is happening with influenza A, causing new types of viral influenza A infections.
Yes, sir. Thank you, sir. The next question to Surampur Sri Krishna garu. Generally, how soon the child is brought to the pediatrician?
As everyone knows, many times in previous days they used to come on day 2 or day 3, but many times most of the patients know what are the cough syrups and fever syrups, so they are giving a trial for 3 to 4 days, then they are coming to the pediatrician most of the times. So they may, by the time they come to us, they might have used the antibiotics and some cough syrup and some even antipyretics also. So
Yes.
usually on day 3, day 4, they do come. Here the thing is, the why it is so important that antiviral drugs, especially oseltamivir, if it is started in first 48 hours, it shows the best effect.
Yes, sir. That's true, sir. Most of because Google is there, treatment part is there, and the medicines are on the counter, OTC on the counter. They are available freely for the patients, and pharmacist himself thinks that he is a doctor and gives the dispenses the medicines. So this is the system where in developing countries commonly seen. So they try for in spite of spending money for the consultation and other medicines, they spend 100 rupees or 50 rupees with the pharmacy, and they take the medicine and trial for 2 days. Then if doesn't subside, then they approach the pediatrician, sir. So this is the common scenario in our Hyderabad and all the rural also. So next question to Sunkuj Bhaskar, sir. Should Oseltamivir be started empirically or after investigations?
Very clear-cut answer that it should start empirically when you strongly suspect it's a case of influenza, lower respiratory tract infection. You should start and do not wait until you get the RT-PCR reports. Because there were many studies conducted, and the retrospective medical chart, the review of 442 patients was conducted, and the subjects were divided into four groups based on the time of oseltamivir administration. Those who were administered less than 2 days, those who were administered between third and seventh day, and those who were administered between eighth and 14th day, and those who were administered above beyond 14 days. So, but the meantime was the oseltamivir administered at or on fifth day of the symptom onset. So, to cut short this entire the graph, the earlier initiation of oseltamivir administration after symptom onset significantly reduces the severity of the infection, severity of the lower respiratory tract infection, complications, hospital stay, and also it decreases the mortality with this influenza infections. Even even if you happen to see them later on beyond 48 hours, better to start at the earliest opportunity. Even that it has showed considerable potential for reducing the complications and decreasing the duration of hospital stay.
Just I'll add one point, sir. Basically, everyone gets doubt whether any fever with cough, whether it's a bacterial or viral. Once the viral, of course, now the present recommendation is whenever the lower respiratory, straight away you can go for oseltamivir, uh, pending the result of the viral panel. So, how to differentiate between bacterial and viral? The even IAP many workshops also says that if anyone else in the family is having the same symptom like cough, cold, and fever, and this child is having 99% it is viral, not the bacterial. This is one good hint that it is a viral infection, not the bacterial. So obviously, here you can postpone the thinking about bacterial antibiotics, then think about the antiviral drug. Similarly, in a short span, more than one area of the body, like both upper respiratory and lower respiratory, are affected simultaneously, like a cold, rhinorrhea, and even the cough. Both are there within 2 days of the time. Most likely, it is a viral infection than the bacterial infection. Similarly, a severe bouts of cough that is almost dry. Most of the times it is dry or very little sputum. Also, mostly it is viral, not the bacterial. That means instead of thinking like a reflex action, some of the doctors are writing the antibiotics. It is better we go for antiviral drug than the antibiotics by looking at this picture. That is, more than one member in the family is suffering, and both upper respiratory and lower respiratory tracts are involved at a time, and third is a severe bouts of dry cough, and all these three are suggestive of viral infection. So you can suspect by this, and if you suspect viral infection, that too with a lower respiratory signs, better start oseltamivir.
Okay, sir.
Yeah,
That's
one more
great,
thing
sir.
I would like to add. One more thing I would like to add. If there is a multi-system involvement, try to
In
think of
short period. Yes, sir.
in short period viral infection. And
Yes, sir.
secondly, because nowadays we are seeing many children coming with fever, rhinorrhea, cough. nausea, vomitings, some amount of
Diarrhea,
diarrhea, some amount of
diarrhea,
diarrhea.
skin rashes. Yes, sir.
So, and secondly, when there is no fever, child looks very healthy, comfortable. When there is fever, child becomes dull and irritable. So some of these clinical points will give us the right direction for the treatment.
That's why, sir. It is always clinical acumen to great extent, which is useful to diagnose the case, sir. So, next, Sri Krishna garu, what are the factors on which clinical response to oseltamivir depends?
As we have discussed already, that early suspicion and early initiation of antiviral therapy is the most useful thing to have a best clinical response. Apart from that, the depending on the child immune status also, like the prognosis, poor prognosis seen in immunodeficiency states. So even in that case also, early initiation may be useful.
Yes, sir. Thank you. The next question, sir, to Sungoj Bhaskar, sir. Generally, how long should oseltamivir be administered?
Yeah. Again, it's for those who have joined recently. They, for therapeutic purpose, we use oseltamivir for 5 days with 2 doses per day. That is BID. Whereas for prophylaxis, we use it for 10 days, but once a day, OD. And since we pediatricians, if you remember the last line, that would be enough. 3 milligrams per kilogram twice daily for children. If you look at the volume of oral suspension of the oseltamivir, that is Fluivir, you can simply say 10 kilos, child weighing 10 kilograms can be given 2.5 ml twice a day for 5 days. The same thing is depicted here. Children 10 to 15 kilograms, 2.5 ml BAD. It more or less comes to the same 3 milligrams per kilogram per dose BAD. If it is 15 to 23 kilograms, 90 milligrams per day. If it is 23 to 40, 120 milligrams per day in two divided doses. More than 40, 150 milligrams, it again goes to the bracket of adults. That is 75 milligrams twice daily or
Yes,
150 milligrams divided twice daily.
that's true, sir.
Myself, I remember it as 3 milligrams per kilogram twice daily. 10 kilos, a child weighing 10 kilograms should receive 2.5 ml of Fluivir twice a day for 5 days. For
Yes, sir.
prophylactic purposes, 3 milligrams per kg per day, once daily for 10 days. Prophylaxis probably is not recommended for infants below 1 year. That I need clarification. And as well, even for therapeutic, it should not be given for infants, newborns below 10 days of age. Yeah.
Yes, sir. Great, sir. Easy to remember, sir. 0.25 ml per kg per dose should be given for 2 days, 2 times a day for 5 days. And chemoprophylaxis, same dose for 10 days. That's it. So that will be the best remembering for the pediatrician 0.25 ml per kg per dose. And the next question to Surampur sir, Sri Krishna garu. Do you prescribe antibiotics concurrently?
As I already mentioned that as per the IMNCA guidelines, we should think, even though the picture 70% of the pneumonias are viral, antibiotics are recommended in IP cases, admitted cases, and the guidelines are clear-cut guidelines are there as per the age. On other hand, if it is OP case, they don't require antibiotics if it is a clear-cut viral infection.
Yes, great, sir. The IMNC guidelines means integrated management of newborn and childhood illnesses. So that is the guidelines for us. We have to follow those things for that, and also personal hospital policy. Our own hospital policy will be there to start the antibiotics or not. So all the corporate hospitals and bigger hospitals will be having the hospital policies where that will be followed by the consultants there. And next question, sir, Sungaj Bhaskar, sir. How is oseltamivir tolerated? Are there any major adverse effects of oseltamivir?
Yeah, I think it's a good question to me because I have been using oseltamivir since last 5 years extensively in our inpatients. And I did not see major adverse effects with oseltamivir. Maybe a few cases of nausea and vomiting. Even that, we don't know whether it is due to the drug or due to the cough. So we didn't see any major adverse effects with oseltamivir. though literature says so many things. But there are some serious adverse complications which we should have them in our mind, particularly the skin lesions. They can have Steven Johnson or toxic epidermolysis necrosis or some sleep disturbances, some psychiatric issues, behavioral problems. All these issues are there, but they are rare. I didn't see them in my 5 years experience.
Yes, sir. Thank you, sir. Next question, Sri Krishna Garu. Any contraindications and precautions to use of Oseltamivir?
As such, there is no special contraindication except the serious hypersensitivity to oseltamivir or its component or any component of the products if that might have occurred before. Second is the drugs like probenecide or dichlorphenamide. They can increase the risk of side effects of oseltamivir, but they are very rarely used drugs.
Yes, sir. That's the safest drug, sir, we have seen in all the patients, in inpatients also. Oseltamivir is a lovely drug and will not have any side effects. And easily available is none other than Fluvir, where the hetero makes. And the summary, a proper diagnosis can and early treatment can
But see
prevent
that
the flu. Yeah, please, sir.
one caution is if we are dealing with a child having compromised renal function, then
Yes.
we need to adjust the dose of oseltamivir.
That's
That's the
true,
only.
sir. Since nephrotoxicity is and other few coexisting drugs are given, then we have to take care of the dosage schedule. So, summary: proper diagnosis can and early treatment can prevent flu complications, and empiric use of oseltamivir reduces lower respiratory tract complications, hospitalizations by 59%, and antibiotic use by 25%. So, WHO, American Thoracic Society, and also Ministry of Health and Family Welfare recommends empiric use of oseltamivir, and also we have to before 48 hours start the oseltamivir and give a best result for the child. Thank you, my panelists, and special thanks to Hetero Healthcare and Prashant and team who had done this webinar. Thank you.
Thank you. Thank you very much for giving this opportunity.
Thanks, Dr.
Thank
Sridhar.
you.
Thanks, Dr. Sri Krishna. Thanks, Dr. Sankosh. It was a lovely webinar with a lot of insights into the current cases and the management guidelines. I'm sure the audience has benefited out of it. Thanks once again. Thanks,
Thank,
Nagadevi, for IT support. Thanks, Samriddhi, and thanks, sales team of Hitro for super coordination. Thank you so much. Wish you a very
Yeah,
good
thank
evening,
you,
sir.
Varuna.
Thank you.
Thank
You
you.
can sign
Thank
off.
you.
Thank you.
Thank you.
thank you, sir. Thank you.